Okay, thank you very much. Karen, I can start. Welcome, everybody. Hopefully some more people will join us, but I think there's quite a bit of discussion that we have to get through, so we might as well just start. Can you hear me well? Just a thumbs up somewhere.
Yes, Prof, we can hear you.
Great, thanks. Can you see that shared screen?
Yes.
And is that the right one? You see a full screen presentation?
Yeah, it's a full screen presentation one.
All right. Okay. So it's going to be very interactive. I just want to get a list of the participants up where I can see it. Okay, there we've got it. All right. So I'm going to switch my camera off just to save a little bit of width. Let's find that. It's disappeared now. There we go. All right. So we're going to address in the next hour or so colorectal cancer liver metastases, and they're going to be interactive discussions that we will base on a case, but I'll just start with some of the basics. There we go. Right. So if you have to tell a patient with newly diagnosed colorectal cancer, and you get the question, what are the chances that this cancer has spread in terms of the liver and other organs? What will your answer to the patient be? So Yalda, you can get it started.
So Prof, the incidence of the around 40 to 50% of people can have a liver metastasis, but that's not the true incidence based on the population. It can be 20 to 30%.
Okay, and that's liver. What about the other organs? What's the second most common organ that would be?
The second most common organ is the lung. I'm not sure about the incidence of lung metastases.
Okay, so yeah, so that is absolutely correct. So if you read the textbooks, they're going to tell you between 40 and 50% of patients have liver metastases. That's a misnomer. So there are at least three population-based studies that show that it's probably somewhere between 25 and 30%. And so those are patients that at the end of the course, whether they're cured or whether they have passed away from the disease or old age, that have shown to have had liver metastases, regardless of when they were detected. Okay, so the 40 to 50% is wrong. It is somewhere between 25 and 30%. Right, just the patterns. These are how the metastases are distributed. So liver, as I said, just above 25% in the series that we did on a population-based cohort in Sweden. The combined other metastases, regardless of where they are just under that, just under 25%, or that it was in this patient group. And you can see here the most common lung metastases, and these were patients that were followed for 5 years after and all of them were followed up after the diagnosis of the primary tumor. And that is followed by peritoneal metastases and then distant lymph node metastases that are outside of the drainage area of the tumor. So pretty much what we see in clinical practice. All right. So here you can see how these patients present in terms of liver and lung metastases. So we're going to talk a little bit in more detail about these, but you can see, so of the total amount of patients that were diagnosed with liver metastases there, quite a significant amount of them were diagnosed in the beginning there, and then sort of after that, and somewhere here at about 3-4 years, very few patients very few patients where the liver metastases are presenting that late. Lung metastases are a little bit different. This is in spite of CT scans being done, they tend to come a little bit later. So more of them are detected after the treatment of the primary tumor. All right. So, sorry, I just have to quickly type this. Sorry, Cobus, I'm just in a lecture. I'll get back to you. Right. So synchronous versus metachronous colorectal liver mets. I don't know who are registrars and who are fellows, but I'm just going to put it out there. Let's ask Gert van der Merwe. Gert, what do you understand with synchronous versus metachronous liver metastases?
Prof, so synchronous metastases are metastases that present at the time of diagnosis of the primary or within 6 months after the diagnosis of the primary, whereas metachronous liver metastases is liver metastases that present more than 6 months after the diagnosis.
Okay. So Gert, what does synchronous mean?
Synchronous means at the same time, and well, the thought behind it really is that for the 6 month time split is because the metastases were likely there at the time of the diagnosis of the primary. It was just not clinically detectable at the time. So I think that's really what the time frame refers to there.
So what would be the difference between metastases that are diagnosed 7 months after the primary was removed? Were they not there in the beginning?
So I think it's likely to also be 7 months, have been there at the time of the primary diagnosis. However, I think the 6 months is just a cut off that sort of sort of an artificial cutoff, but I think it speaks to the likelihood of the metastases being there at the time of diagnosis of the primary.
Okay, and what about metastases that are there 3 years afterwards? Weren't they there from the beginning?
So I would answer the question in terms of saying, look, they all arise from, all metastases arise from the primary. However, they could have been in transit in the lymphatic system before spreading hematogenously prior to that, or again, it could have been just depending on the tumor biology, a slow growing thing, slow growing lesion that just didn't present at an earlier stage.
Yeah. So Gert, you're absolutely right, and there is no right answer here. There's going to be some consensus meeting, I think, in the beginning of December, where they're going to sort this out. I will tell you my take on it, but everything you said is actually correct, and we'll come to that. So if you look at the metastases or the variation in the definition of synchronicity versus metachronicity in the literature, I like this one, the diagnosis and or operation of the primary tumor. Because once the primary tumor is out, and I say that with a little star at the top that I will explain at the bottom, the metastases in the liver are there when the primary tumor is removed. And they can be detected up to the point of the primary tumor operation with palpation or endoscopic ultrasound. So I like the diagnosis, the definition where we say at diagnosis or at the operation of the primary tumor. Obviously, if a patient is not operated, it's at diagnosis. In other words, whatever diagnosed, the colonoscopy or whatever it was. All the other times are superficial, are sort of arbitrary. 3 months, 6 months, 12 months. Those are the cutoffs that have been used in the literature. There's no real consistency, and as I said, there's not consensus. We will hopefully have it after a meeting in December. But what was always said is that metachronous metastases are worse than synchronous metastases. I don't think there's really any evidence for that. What we've actually done some years ago, it's been published since, but was to look at patients in the literature, at all the articles that looked at this, and you can see there the different cutoffs. And you can see here that the results were all over the show, that there was not really any consistent worse prognosis in patients with metachronous versus synchronous, regardless of the time that you were going to look at that. And we tested this in a cohort of patients where we took all the patients in a cohort of 1,200 patients, more or less, in a population-based cohort. We looked at the ones that that got liver metastases, and we populated graphs to simulate at operation, 3 months later, 6 months later, 12 months later. There's certainly a little bit of a trend, but none of these reached statistical significance. So it may be that patients with synchronously detected metastases have a slightly worse prognosis, but certainly in this study it wasn't significant. The reason why I make a big deal about synchronous versus metachronous metastases is not so much that it's a diagnostic parameter. It's really about therapeutic implications. The best chance for a patient is if you, at the diagnosis of the primary tumor, have the real extent of the disease in terms of metastatic spread. So this is again that cohort patients that I showed you, and you can see here just about there. So 55% of patients that eventually had liver metastases, in those they were diagnosed before the operation or at the time of the operation, and that's that point there. So about 55, I think it's 57% of patients. And then afterwards, that's how they presented. And it's really not on whether they are present. I think they are present, all of them, that it'll start still at the top, and I'll explain to you why. Because if you perform really bad imaging, this is the amount of patients or the proportion of patients that you're going to detect synchronously is going to be fewer. And if you really up your game with imaging, you're going to detect more. So it's really not so much a question of whether the metastases are there or not. They're all there. It's just that we don't detect them. We're probably never going to get to 100% because some of them will be undetectable. But I suppose that we can probably push it with better imaging to somewhere around 60–65%. So if they're there, we will detect 65% of them. And it's more a parameter of good imaging rather than having an impact or strong impact on survival. All right, so I'm going to show a case here. Let's just see who we're going to get here. Wanga, I'm going to ask you to comment on this case. It's a young lady. She's 35 years old. She underwent a colonoscopy. She's got a right-sided tumor in the ascending colon, and this is her liver CT. The lungs were clean. The primary is not symptomatic. And let me just go through it here. And this is what we've got. So I'm just going to go through it like this. And then I'm going to ask you to describe for me where the lesions are.
We've got a lesion that I could see in segment 8 and so segment 2 up.
So you can stop me when you see one.
You can stop there, Prof. There is a lesion there in the periphery of what looks to be segment 7–8, and there's another lesion posterior that looks to be in segment 7 as well.
Right.
Down, there is a lesion in segment, I think that's probably segment 2.
Right.
On the left side, further down. You can't really assess the relationship of the tumors with the vein. I don't know if it's just the scan quality. There's another lesion here in segment 8.
Approaching the portal vein, the portal vein. So that's actually the area where it's almost in all the segments on the right. So on the left portal vein, remember that's a vertical plane, and it's more or less in the plane of the right hepatic vein. So that one is sort of at the crossroads, at that cross where segments 5, 6, 7, 8 meet. What about at the top of the portal vein there in segment, between segment?
That looks like between segment 2 and 4, probably 4A.
Yeah.
There's another one that's sort of spanning between segment 8 and 5.
So we're down now, we're below the portal vein, so that would be segments 5 and 6 on the right.
5 and 6 on the right, yes.
Okay, and there I show you the whole lot, and this is one more that you have there.
Yeah, there's another one there in segment 3.
Okay. So are you happy with this imaging?
Yes, we've seen the imaging, Prof.
Yeah. Do you think you will go further and plan your surgery on this, or is there anything else that you want? We did chest imaging, it's clean.
That's clear. Yes, Prof. So I think with this patient, Prof, who's 35 with a right side tumor, we don't have very much favorable things. I would also like to send this for MHLS and for.
Well, we're not there yet. We will get there.
Sure that we're not dealing with.
My question was, are you happy with this imaging in terms of the liver, or is there anything else you want?
I'd like to do an MRI here, Prof. I would not be able to plan resection because there's always some lesion that maybe we may not be able to detect based on the CT scan alone. Yes. Okay, so
that's still a debate going, but MRI without any doubt is the better method. A bland MRI without contrast, probably not. But, and I'm going to show you now why contrast enhanced MRI, and specifically MRI with a liver specific contrast, is better. And also remember that MRI becomes increasingly functional. In other words, you can actually, it gives you not only the image, you can make diagnoses on, or it can sort of support malignant diagnoses. And we're talking about diffusion weighted imaging. We're not going to go into that in detail, but in the exam, if you have to explain to people why you would like to have an MRI, and I will give you a little bit of evidence I will give you now, the resolution of the MRI in general is better. When you add a liver-specific contrast, it's even better. Your detection rate definitely goes up, and with other sort of functional imaging, part of the MRI sequence, specifically diffusion-weighted imaging, you can increase your detection rate even further, or characterize these lesions better. All right, so if we just see how things are done nowadays, let's go to the next one. No, I wanted to go here. There we go. So we still use CT as sort of the workhorse. And up to quite recently, and I think that's still the case in most units, is that as part of the diagnosis of the primary tumor, there will be a four-phase CT scan. In other words, a liver-dedicated CT. Post-resection follow-up, most people will go with a sort of a portovenous phase, because that's the phase where we diagnose most of the differences. In other words, if you can ask for one CT phase, the arterial is not good, without contrast is not good, the late is not good. The best phase to pick up metastases, where the contrast between the tumors and the parenchyma is the highest, is the portovenous phase. And if you pick up something on that, you go back to a 4-phase. So those are patients post-resection. And MRI is still regarded as a problem-solving tool. The reason why MRI, I'm just going to skip over these, and I'm actually going to skip over, wait, no, I have to go back to that one. The reason why MRI is better, remember that 50% of primavist, or EOVist, as it's called in the United States, is a little better than CT. The contrast is excreted 50% through the kidneys, 50% through the liver, And on the late portal venous phase, or sorry, the delayed phase, about 20 minutes after the contrast has been given, this is what you're going to see. You're going to see a very, very light background of the liver because the contrast is now inside the hepatocytes. You sometimes see a little bit of biliary enhancement. And anything that doesn't contain hepatocytes are going to be like little holes in a Swiss cheese. So you can see the vessels there. These ones are actually supposed to show you that there are metastases at that arrow at the top there that wasn't there. A little bit wrong, these arrows, but that one there was not seen on the CT scan. And there you have a little bit of diffusion-weighted imaging as well that shows the restricted diffusion of that liver. And you couldn't see that on the CT scan. The other thing, there are some cysts in this liver. They also show very well on MRI in T2-weighted sequences, where you can distinguish cystic lesions from solid lesions. I'm going to go over these because we're going to run out of time, but there is reasonable evidence now that the outcomes are definitely better of patients where you, or let me put it to you this way, the detection rate is better. As I said at the beginning, it's important to define your disease so that you can have the complete picture before you start making your plan. All right. Shall we ask, let's see who else is here. Andries Steenkamp, can you define resectability for us?
Yes, Prof. It should be there should be a functional liver remnant present that's got adequate liver arterial supply, portovenous supply, biliary drainage, and also venous drainage. Yeah, if the patient didn't have chemotherapy, it's debatable, but some people would say if it's a healthy liver, 25%, if they had chemotherapy up to 50%. Yeah, and there shouldn't be any unresectable metastatic disease outside that cannot be resected. Okay,
so thank you for that. We're just going to go to how it was before. Is that they were really everything was based on the tumors. So the number of metastases, the size, where they were, macroscopic surgical margins, and at that stage it was 1 centimeter was absolutely necessary, and extrahepatic disease was a no-no. And it was really quite easy to make the decisions. You barely need a MDT for this. You click the boxes, the patient was either resectable or unresectable. So this is the new definition, and you were right. I would, if I were going up for the exam, I would kind of rehearse like quite a smooth description. So there I talk about the contraindications. So, but you can also talk about the indications. So first of all, you have to be able to, one way or the other, achieve a R0 situation in the liver. And that means that what you leave behind has to be free of tumor. It doesn't need to be at upfront, but at the end of your stage resections, whatever you plan, the future liver remnant has to be free of tumor macroscopically, and it has to be sufficient in terms of volume. And then you can qualify it by saying that it has to have arterial portal supply, and there should be venous and biliary drainage. And the relative contraindications, because extrahepatic disease, the modern definition is not an absolute contraindication. And progression on chemotherapy, that's also regarded as a possible contraindication. We also have to qualify. There's a difference in patients with size progression and patients with numerical progression. So if you've got a patient with size progression, say a patient that presented 3 years ago, or after 3 years with a single met in the liver, you try chemotherapy, it seems to be still being grown. That means that single met is chemo unsensitive or resistant, as opposed to a patient that on follow-up imaging showed there was 5 and now there's 10 and there's 20. That's a patient where we haven't really detected the extent of the disease, especially in patients where it happens quite early. We've spoken about this. If you describe the future liver remnant, and it's really important because the biggest cause of postoperative mortality nowadays after liver resection is is liver failure. These patients very seldom die of intraoperative misadventures. And as I said, sufficient volume and quality to sustain the immediate post-operative function and to allow for post-resection regeneration has to be tumor-free and intact arterial and portal supply. Okay, I'm not going to ask a question on just this, a new concept, or not that new. It's probably already 3-4 years old, where we talk about oligometastatic disease, and that is sort of one step further from the pre-2010 paradigm that I showed you there. And that is that the primary in this concept of oligometastatic disease just becomes another tumor site. In other words, every metastatic site plus the primary tumor site you have to add. So as I said, the primary is included in it, as you see there, predominantly visceral metastases. So the definition of oligometastatic disease would be metastases at 2 to 3 sites. You can see these guys don't commit in this. I would have said 3 or 2, kind of make up your mind, and then it should be 5 or less, but they say in that even sometimes it can be more, and that just gives you an indication that there are many other factors that we look at in patients as well, things like chemosensitivity. Now, so for instance, the patient that we looked at, that patient has got at one site, but there's probably about 7-8 metastases in that liver. So per definition, that patient would not have oligometastatic disease. So I think this is a concept in evolution. But I think you need to know kind of the basics. But I would still go back to the previous definition that we had there to describe, let me just get it there, to describe a resectability. All right. So in oligometastatic disease, we can potentially go for a curative approach. And then they say in non-OMD that the long-term, the plan is really to get a long-term disease control, because we know that is associated with better survival, and then although unlikely, potentially cure. So you can see these things are very, very vaguely written, very vague for guidelines. They're not really guidelines. I think it's a description of a concept that needs to be refined. This is how I think about it nowadays. We get patients that are easily resectable. We get patients that are clearly unresectable, and we get this in-between group. And that's more or less how they are distributed. Since still somewhere around 60% of patients will be unresectable. Patients in the curative, upfront curative, and potentially resectable groups after multimodality conversion, I would give sort of 20% at this stage. All right, so I'm just going to refresh your memory with this. This is what this patient, oh, sorry, no. This patient, I don't need to refresh your memory. This patient received chemotherapy, and this is what the, no, sorry, I'm not talking the truth. This is the original scan, just to show you again the extent of the disease. All right. So how will we convert this patient? Well, let me first ask what is a potential strategy in this patient. So we can come back to you, Yalda, because you had some, you could have, you looked at the original one, or sorry, Wanga used it, or looked at it, but you can give us your take on it. So you get presented with this patient in the exam, forget about the fact that the primary tumor is still there, but what is the potential for you? What do you think is potentially a strategy in this patient? Is there a future liver exit that you can define?
So Prof, when I'm looking, the most of the area of the liver which is disease-free is basically maybe segment 3, segments, mainly right side of the liver. There is I think a big area of 7-8, which might be salvaged.
Mm-hmm.
the disease is mainly central, and
Yes.
there's some extent on the left side as well.
Yeah,
So this patient is not upfront. We cannot say that he's potentially resectable.
Yeah.
We can do a conversion therapy. We have
Just tell me what is your future liver remnant here?
I would say most probably 8 is gone. 7, 6, maybe a bit of 2.
Yeah, so no, but you have to decide now.
I will go with 7, 6.
Okay, so we just look at 7, 6 again. That is sort of on the border of 7.
Isn't it more toward 8, Prof? I mean,
Yeah, I mean, if you look at, you can't see the portal vein, sorry, the hepatic veins, but it runs somewhere there. So I would think it's kind of almost over 7. And then you come down. That is
there is another
definitely,
one. Yeah.
and all of this down there is in 5 and 6.
5 and 6, yes.
Look at segment 2 and 3. You've got one there, superficial, but one at the top of the portal vein that we showed there, and you've got one there, also superficial.
Mm-hmm.
So I would argue that the best one in this patient in terms of cleaning is segment 2 and 3, because I think you're going to have quite a hard time to clean. Segment 6, I think, is pretty much lost. Segment 7 is a little bit threatened, but by what you see up there. So in this patient, one can argue it, but the other thing, one that worried me is this one there. There is one in segment 7 there as well, even though it's superficial.
Okay.
All right. So how will you convert this patient?
So the conversion therapies we have mainly, if I want to classify it, we have 2 main types: conversion to the tumor and the conversion therapy for the future liver remnant or the liver. So with this patient who's having a synchronous liver metastases, I think after discussion in an MDT, we can attempt to have neoadjuvant chemotherapy to see if we can downsize it.
Yeah, so why would you give this patient? So remember that there are 3 kinds of chemotherapy in this situation. You get neoadjuvant chemotherapy. That is, we decide that we give it to a patient that is basically resectable, but we give them for oncologic indications, give them preoperative chemotherapy for the liver. The guidelines, they are still a little bit all over the show. You know that in our MDTs there's a discussion every time, but that's the one, adjuvant. Then you get a patient where you give them conversion chemotherapy. In other words, this patient is not resectable, or you want to get the tumor smaller to make the whole resection an easier endeavor. And then you get adjuvant chemotherapy after the operation. All right, so what would you call it in this patient? Is it neoadjuvant or is it conversion?
I think neoadjuvant to see the response of the tumor to the chemo.
Yeah, so I think it's a little bit of both in this patient, because clearly if we can get those tumors on the, we just go there, if we can get them smaller, that one, and that one, we sacrifice a little bit less tumor in the future liver remnant, segment 2 and 3. And remember, 1 is also part of the future liver remnant. And we may be able to save a bit of parenchyma so that we don't need that much growth if we're going to do volume manipulation. All right. So just to come back to that, to summarize. So as you said, tumor targeting, and that's conversion chemotherapy. There's a possibility of stage surgery that we probably have to do in this patient. And that local ablation techniques is actually a part of tumor targeting. And it's been accepted that the deep-seated lesions, for instance, one can ablate with a safe margin. And then we've got future liver remnant targeting with portal vein embolization or portal vein ligation. We'll come back to that. And then we've got sort of other combinations. And ALPS is a sort of a combination of usually cleaning a liver remnant, sometimes a liver remnant that is too small where portal vein embolization fails, but it's usually part of a combination. And then finally, we're just going to say a little bit about liver transplant. All right, so if you have to choose the chemotherapy, this is again from the Annals of Oncology, and that's the article where they very nicely describe the concept of oligometastatic disease, that if you've got an easy liver and sort of excellent prognostic, oncological prognostic criteria, whatever they may be, maybe a patient with a single metastases 3 years after the primary was operated, no preoperative chemotherapy. If we have patients that with a good prognosis, this is also not very well defined, that where we want to give preoperative chemotherapy, we would give preoperative or perioperative FOLFOX, in other words, a little bit before and a bit after. And in a patient with bad prognostic factors, we would give them preoperative and see what happens. If patients progress on chemotherapy in terms of definitely a number of metastases, but certainly also in terms of size, if there are a lot of bad prognostic criteria, one would go to second-line chemotherapy, and you would hold back with surgery there because it's not sure that this patient is going to benefit from resection. And then if you've got the combination of a very difficult liver, and this is where we are in this patient, the chemotherapy that you would choose would be the best systemic therapy. And that's often, if you can afford it and it's available, a combination of conventional chemotherapy, FOLFOX, FOLFIRI, FOLFIRINOX, and maybe a biologic. All right, so this is the one that I wanted to show you. The patient has had the chemotherapy, and this is what you see. You remember what it looked like? This patient had a very, very nice response. You can see the tumors are a little bit more hypodense as on the original imaging. And you can see the size of these are definitely a little bit smaller. All right. So chemotherapy-associated liver injury. Who else are there any colleagues here that can just put up their hand if they're writing the exams now or not? Because I don't know who's actually on for the exams. Or a volunteer to talk about this. Otherwise, I'm going to choose. All right, Dr. Nasir. Do you want to tell us a few things about chemotherapy-associated liver injury?
Okay, Professor, thank you. I think I have just looked for information about this. I think in that those patients who can started chemotherapy, they will end up by some hepatotoxicity and some liver injury that could end up by increase in the liver function test. And I think that's all that I know.
Okay. Have you got any idea what kind of liver damage liver damage chemotherapy can cause?
No.
Okay. So I'll quickly take you through that. So we're talking about CASH, so chemotherapy-associated liver injury, and there's basically three types. That you can get what we call a yellow liver. In other words, you get sort of fatty liver disease. You see there. Then you get a condition that's called steatohepatitis. It doesn't have got a color associated with it. And then you get sinusoidal obstruction. what we call a blue liver. You can't see it very well, but you can see there some bluish areas in the liver. And it's caused by a obstruction in the portal flow at the level of the sinusoids. So these are the drugs that cause it. So if we talk about steatosis, it's 5-FU can cause that. If we're talking about sinusoidal obstruction, so SOS, it's easy to remember, it's the O that causes it, oxaliplatin. And steatohepatitis, in other words, inflammatory condition in the liver, is irinotecan. So of those, all of them are associated with an increased morbidity, sort of a slightly different symptom complex that they can, or damage or complications that they cause. But it has been shown that irinotecan, in other words, steatohepatitis, that in a study, one study, there was a 90-day mortality, higher 90-day mortality associated with it. So the two that we really worry about, sinusoidal obstruction, because you've got a higher pressure in the portal vein, and these patients can, and that's why they bleed more, need more transfusion. And when it comes to steatohepatitis, problem with the function of the liver. In other words, you've got a compromised future liver remnant. Just to come back, what we said about the volume, the evidence for how much volume liver you have to leave behind is based on opinion. There's never been a study to say that it should be 20, 25, or 30, or 35. They basically sent around a survey, I think it's about 10, 15 years ago, where the mean or the median was 25%. So it was consensus based, not very scientific. And then I would be a little bit careful to say that if there is chemotherapy, it has to be 50%, because as cirrhosis, and I don't like it when they say, if it's cirrhotics, you have to make it 45% or 50%, because as with cirrhosis, the range of dysfunction in the liver is from very, very severe to very minor. And with cirrhotics, for instance, I mean, there are some cirrhotics you can't touch. You can't even leave 100% of the liver behind on them. If you touch that liver, they're going to die. And there are other patients with very, very well preserved liver function that will basically tolerate any operation. And it's a little bit the same for chemotherapy. So I would rather phrase it as that the volume has to increase as a function of the dysfunction. In other words, the more abnormal it is, the higher the future liver remnant volume should be. I'm not going to talk about how we calculate the liver volume. I don't think we have got time for that today, but it's basically a percentage, the future liver volume as a percentage of the functional parenchymal volume. So you have to deduct the tumor volume from that. And so it's a measurement that we do on CT. And in the case of the total volume liver, we can also use the Vorti formula to predict the future liver remnant. Sorry, to predict the total liver volume based on the body surface area. It will give you in milliliters a volume, but you still have to go back to the CT scan and measure the future liver remnant. That the Vorti formula doesn't predict. So it basically just tells you what the total liver volume is. Just a few words about local ablation. Those are the methods. Radio frequency, microwave. We've moved away from laser because it's very small ablations that you achieve. And cryotherapy has never been a big thing. It makes a little bit of a comeback. And then you also just have to know that there's the possibility of irreversible electroporation. Very, very expensive, but very appealing in that you can burn close to bile ducts, and the risk for strictures in bile ducts that are caused by radiofrequency and microwave ablation are far fewer. I'm going to skip that. Volume manipulation. Go one back. The options there, Dr. Ede, what volume manipulation, we've spoken about them, but if you've got an opinion about which one is best, portal vein embolization, portal vein portal vein embolization or portal vein ligation?
Prof, I think portal vein embolization is better because you can achieve a supraselective embolization of the portal vein branches.
Okay, so you can achieve that with ligation as well. You can actually dissect out the sectorial branches, and you can ligate those. It's not completely true what you say. What it does allow you to do, however, if you would dare to do that, is to, in the case where you're going to leave segment 2 and 3 as a future liver remnant, that you can embolize the segment 4 branches. We're going to go through this, and I'll just explain to you what I mean. So in this patient, we did a portal vein ligation, but we do sort of a combination. We also inject the portal vein. The reason why let's just stop where we see the portal vein, the left portal vein. So you can see it there. So you usually, remember that you do it with a puncture of the portal vein. Usually you puncture on the side of the liver that's going to be removed. So you puncture the right side of the portal vein and then embolize. If you want to embolize the segment 4 branches, you have to cross over into that part of the portal vein. And then you have to embolize these ones selectively that supply segment 4 from the left. That's where it is. And there's usually more than one of them. People are very hesitant to do that because you can cause a portal vein embolization on the left complete if you get spillage, and then it's game over. Then this patient is not resectable anymore. So what we do, if we would always go for portal vein embolization first. I actually think that portal vein embolization is a misnomer. It should be a portal vein obliteration. You shouldn't just embolize it because that liver is not going to grow very well. Remember that there's backflow from the artery in the sinusoidals back into the portal vein that will maintain the flow there, and there's also crossover flow that may happen over there. So we do a portal vein, and even if you do embolization sort of percutaneously, try to obliterate the portal vein, not to just plug the origin of it because it's not really going to work. So what we would do, as we did in this patient, is that we ligate the right side of portal vein. Once we've ligated it, we would take histoacral, stuff that you use for gastric varices, and we inject it under ultrasound guidance, looking on the liver into the vein until we see a complete obliteration. So you can see in this patient that we achieved quite a good effect. There was almost a 7% growth of the future liver remnant from somewhere around 25 to about 33%. And you can see that there's not much portal flow left on the right. We've knocked it out completely to the anterior sector. There seems to have been some aberrant one there that we didn't completely obliterate, and there's a bit of flow. So, but a reasonable result. And you can see there the future liver remnant that has been cleaned off the tumor at the top and at the bottom. And the one at the top of the portal vein, we couldn't really see. That was we couldn't see it at the first operation, and just decided to take our resection just to the left of the top of the portal vein to include that met there, rather than to risk a thrombosis of that vein. All right. We've mentioned that there's also a bit of evidence that portal vein embolization does give a better growth. But as I said, both of these should be replaced with portal vein obliteration, whether it's done percutaneously and whether it's done percutaneously. Just the ALPS procedure has been oversubscribed, like surgeons do. When it came, it was completely overused. I think most of you know what it means. It's a two-stage procedure where we cut the portal vein, as we did in this patient, that you clean the future liver remnant, that you maintain the arterial and the portal, the arterial supply of the future liver remnant, as in this case, you keep the biliary drainage, and then you go back at the second operation, usually a week later, and after having confirmed the growth, and you do complete the operation. So this is what it looked like. This is at the first operation where you've got the split. You've now divided the parenchyma. That top band is around the right portal vein that you also maintain, because you can't pump blood into the liver with the artery and don't have drainage. There you've got the right portal pedicle sling. People tend to go away from the plastic bag. I still like it because I think your adhesions are fewer. And you can see here on the CT the very nice growth of this part of the liver, the split you see there. And at the second operation, you basically go back and you just, with 2 staples, it takes 15 minutes, staple those 2 pedicles off. And there you've got your future liver. And the reason why you see those things is that those days we did a lot of liver biopsies to look at growth factors and stuff like that as well. Just a few words about liver transplantation. It is an option. In the first study that was published from Norway, where they had, I think, just about 20 or 22 patients, you can see here the follow-up that the overall survival of these patients was 60%. Great overall survival. The disease-free survival was 0. So that means that all these patients recurred. And that's to come back to the original discussion that we had on whether patients that after the primary is out, if they can develop liver metastases. The answer is yes, they can. These are patients that had the primary removed and had the liver removed with all the metastases in it, and in the new liver, all of them recurred. And in most of those patients, they could find a node somewhere or lung metastases that could have been the source of metastases to the liver. But in some patients, they didn't find anything. And there the theory was that, a little bit like breast cancer or melanoma, that you've got circulating tumor cells that years later can present with clinically metastatic disease. So what I said up front, I think we should just sort of by default assume that all liver metastases are there at the time of the operation of the primary, and that we should try as much as we can to detect them. But it's probably not the whole truth, but I think it's probably about 95% of the truth. All right, so simultaneous versus metachronous operation for synchronous liver metastases. Shall we ask Dr. Balil, would you in this patient consider to do a synchronous operation? In other words, we take the primary tumor away at the time of this operation that we've done?
And this patient, he needs a major hepatic resection. So
Yeah.
unlikely going to be done synchronously in this patient.
Okay. So I agree with you. I mean, obviously this is an extreme case. I think to do any other operation with a 2-stage procedure would have been a little bit risky. One can sort of say that at the first operation it was very minor, two local resections and portal vein ligation and obliteration. So theoretically, if this patient was not a 2-stage procedure, I think one could have considered it. But even if it's a small operation, if you get a complication from that colon anastomosis, the whole plan for the liver, and the liver in this patient is the motor of what's going to happen in the end, is going to be scuttled. All right. So simultaneous versus metachronous. They say easy colon, easy liver. I think that's wrong. It's not about whether it's easy or not. It's where there's a high risk of complications or not. It's not only about the operation. A right-sided hemiapectomy for me is an easier operation than the second 6-7 resection, or even though it's regarded as a smaller liver resection. So it's really about the risk of the complications. And again, that whole concept has not been really been validated. A liver resection can be difficult. Doesn't mean the patient loses a lot of blood without a very high risk of complications. But if there's a high risk of complications, I said that still has to be defined in terms of it's better defined in terms of the colon. It's colon resections where there's a high risk of anastomosis. In other words, a colonic anastomosis, usually with left-sided tumors or colorectal anastomosis. So the results, simultaneous versus metachronous operations, is that the advantage of the synchronous operations is that there's a shorter hospital stay. The preoperative morbidity counting together are very much the same, and this has got a similar rate of similar oncologic results. So liver first operation for synchronous liver metastases, that we do when the liver is really the problem, and if we do not manage to control the liver in a patient with an asymptomatic primary, there's probably not that much sense in addressing that primary, and that's sort of I think the summary of that argument. The outcome of liver first strategy versus a conventional strategy of colon first is there's actually no difference in the outcome between the two. So liver surgery first compared to the classical strategy of colon first gives you similar survival benefits. Got about 3 minutes left. Laparoscopic liver resection, I think that's the future. As far as I'm concerned, almost all liver resections are going to be done with laparoscopic surgery. There's one randomized trial that has been done, a Norwegian study. What's going on at the top there is just the way that we do a right-sided hemiapectomy. We're not going to go into details on that. You can see here in this randomized study that they've done, you can see here what favors open liver resection, a little bit quicker, although it was not significant. Tumor margins were a little bit better with the open resection. There were more R1 resections in the laparoscopic group, but blood loss, transfusion requirements, hospital stay, and even morbidity and mortality favored the laparoscopic liver resection approach. Local recurrence favored the open response, and that's probably related to the tumor margins. Disease-free survival and 5-year overall survival in this group was not significantly different between the two groups. So I think laparoscopic liver resection is, if well performed, probably non-inferior in terms of oncological outcomes if you do a proper operation, and there are the advantages of bleeding less. Number of reasons for that. The one is that you work under a higher intra-abdominal pressure. That is the difference between your venous pressure, that's usually where the big bleeding comes from, and the intra-abdominal pressure is bigger when you've got an inflated abdomen with CO2. Just a few words about prognosis finally. This is again population-based data that we had. And you can see here patients with liver metastases where curative intended treatment was performed, as opposed to patients that were treated with palliative chemotherapy and patients with best supportive care. So in this study, the 5-year survival was around 50%. It really depends on your inclusion criteria. If you are very, very conservative with your surgery, you're probably going to have 5-year survivals up in the 80%, but you're probably going to deny some patients some patients potential cure. I think you should be somewhere between probably around 50% for that. Factors influencing survival, just again in the study, just to show you the right and left-sided primary tumor, whole new concept that we had. I'm going to skip over this. It just shows you the impact of MDTs, and we know that it's a very good thing to do. Just the mortality after liver surgery. These are recent German studies that I think is a very good reflection of what the total mortality is. So for major liver resections, for colorectal liver metastases, somewhere around 10% is what they've been reporting. There is a differential survival depending on your metastatic patterns for patients with non-metastatic colorectal cancer. If you follow them, it's a very old population. You can see the survival curve there. Interestingly, it's rare, but patients with only lung metastases, you can see has got a much better prognosis than patients with only liver or liver and lung metastases. So we have to look at lung metastases as more benign in terms of the course, and that's also why lung metastases no longer are regarded as an exclusion criterion for undergoing liver resection. It's MDT decision whether these patients should undergo a liver resection. In the transplant patients nowadays, if they recur in the lungs, in many of these patients, they just watch it to see whether they increase in size or in number. This you need to know that there's a difference between mid-cut and hind-cut tumors in terms of prognosis. I'm going to skip that just to show you that in patients with liver metastases coming from the hindgut, in other words, from the splenic flexure down, have got all takers, whether they were treated or not, have got a better prognosis than right-sided metastases. And you can see here patients that were resected with left-sided tumors, that was their 5-year survival. Patients with right-sided resected, less good over survival. And for patients that were not resected, also left-sided tumors do better. MDT assessment, I think that's something that you have to measure in the exam, or mention that you have to give your opinion but that you will take patients to an MDT. So just to conclude, accurate metastatic staging upfront, it gives the patient the best chance with multimodality therapy and the sequence of surgeries or tumor-directed therapies that are going to be performed. Multidisciplinary management, obviously that's what we do today. And I think that no patient decisions should be made in treatment. Treatment decisions should be made in patients with M1 disease before an MDT assessment, if that is possible. And centralization of these patients to high volume centers or individuals gives you better outcomes. All right, we have a few minutes over. So if there are any questions, we can take 1 or 2 questions. So if no questions, Nasser, you've got your hand up there. It's down again.
Yes, Professor, thank you. Just I would like to ask about one question. If I have a patient with colorectal liver mets and he's potentially resectable and I've started the chemotherapy, but follow-up, the CT showed that either the size or the number increased. Shall we consider it as unresectable, or I can change the chemotherapy?
Yeah, so in that case, I think what would happen in a place where you've got more chemotherapy, so normally if you don't have any other treatment options, I think that patient would, chemoresponsiveness is one of the strongest indicators of a good prognosis. So tumors that are chemosensitive have got a better prognosis of ones that progress on chemotherapy. So if that's the end of your line treatment, I think that patient would be regarded as irresectable. So we do individual assessment for those patients in any case, and there are mutational analyses and that we also do nowadays, and the combination, for instance, of KRAS and BRAF mutations is a very bad one, as opposed to a patient with no mutations, where there may be a chance for second-line chemotherapy or even further lines, and if you can add some of the biologics, that could maybe change the situation. But in general, that patient would not be regarded as resectable. Does that answer your question?
Yeah, thank you, Professor.
All right. Okay, so if no more questions, thank you very much for attending today. And just at the end here, we would just like to thank the ECHO team from University of New Mexico and the ECHO team India that are usually on these meetings. You can give us some feedback in the chat group. The recordings will be available on the Gastro Foundation website. And also thanks to the Gastro Foundation to organizing these sessions. The next meeting will be Monday the 18th, and Dr. Bootle will speak on intestinal failure. So thank you, everybody. Thanks, Karen. Bye.
Thanks very much. Bye.